Welcome to Lecture Boss. My name is Dr. David Averbach. In the next several lectures, we will discuss the pediatric genetic diseases you must know for USMLE Steps 1, 2, and 3, the clinical shelf exams, and pediatric boards. We will first focus on inborn errors of metabolism. This is the first of two lectures on this topic. In this lecture, we will cover inborn errors of amino acid metabolism, carbohydrate metabolism, nucleotide synthesis, and the organic acidemias. In the second lecture, we will cover inborn errors of fatty acid metabolism, urea cycle disorders, lysosomal storage disorders, peroxisomal disorders, mitochondrial diseases, and inborn errors of metabolism that don't fall into these categories. This lecture will be in a question and answer format. Let's start with inborn errors of amino acid metabolism. Name some of these disorders. Disorders of amino acid metabolism include homocystinuria, phenylketonuria, alkaptonuria, maple syrup urine disease, cystinuria, and Hartnup disease. Homocystinuria commonly results from enzyme defects in two metabolic pathways responsible for metabolizing homocysteine. Name the defects in these pathways. The most common enzyme defect leading to homocystinuria is cystathionine synthase, which converts homocysteine to cystathionine. This enzyme uses B6 as a cofactor. If there's a defect in the enzyme or deficiency in the cofactor, you can't ultimately make cysteine. The second enzyme defect is in methionine synthase, which catalyzes the conversion of homocysteine to methionine. The enzyme uses methyl tetrahydrofolate and B12 as cofactors. What are the clinical features of homocystinuria? Infants will have failure to thrive and developmental delay. There is progressive intellectual disability. Children can have a downward subluxation of their lens and other ocular disturbances later in life. This downward subluxation is in contrast to the upward subluxation in Marfan syndrome, which shares some characteristics with homocystinuria, such as marfanoid features, osteoporosis, and skeletal abnormalities. Patients with Marfans will have normal intellectual ability. Patients with homocystinuria may also have fair skin from inhibited melanin production. The high homocysteine puts patients at risk for thrombus formation, arteriolosclerosis, and myocardial infarction and stroke. Additionally, if the defect is in methionine synthase, or B12 or folate deficiency, it can cause megaloblastic anemia. How do you diagnose homocystinuria? There will be elevated homocysteine in the urine and in the blood. In cystathionine synthase deficiency, there will be low cysteine, but elevated methionine in the blood. In methionine synthase deficiency, or a lack of its B12 or folate cofactors, there will be low levels of methionine in the blood. How do you treat homocystinuria? The treatment will depend on the enzyme defect. For cystathionine synthase deficiency, you can supplement with high doses of B6. The patient should also have a diet low in methionine and high in cysteine. If the enzyme defect is methionine synthase, you can supplement with methionine or give B12 or folate if these cofactors are deficient. Let's discuss phenylketonuria, PKU. This disorder involves a defect in an enzyme involved in the catecholamine synthesis pathway. What enzyme is this? What reaction does it catalyze? And what cofactor is required? The enzyme defect in phenylketonuria is phenylalanine hydroxylase. This enzyme converts phenylalanine to tyrosine. It requires tetrahydrobiopterin, BH4, as a cofactor. An impaired synthesis of BH4 can also cause PKU, although this is less common. Another cause of phenylketonuria can be if the mother has the disorder and she doesn't adhere to a strict diet. The excess phenylalanine can cross the placenta and cause disease in the fetus. What are the clinical features of PKU? The clinical findings result from the buildup of phenylalanine, which is toxic to brain tissue. The patient will have delay in intellectual and motor development, seizures, and growth restriction. Other clinical findings result from the failure to convert phenylalanine to tyrosine, which is required for thyroid hormone synthesis, as well as the production of other neurotransmitters and melanin. The patient may have dermatologic findings such as eczema, albinism, and a musty odor. What are the diagnostic tests for PKU? All newborns are screened by measuring phenylalanine levels a few days after birth. Levels may be normal at birth because the mother's phenylalanine hydroxylase can metabolize it. There will also be increased phenylketones in the urine. What is the treatment for PKU? The patient must adhere to a low phenylalanine, high tyrosine diet. This includes avoiding sweeteners such as aspartame. Patients can also take a synthetic form of BH4 called sapropterin to enhance phenylalanine hydroxylase activity. There is an enzyme supplement called pegvaliase that can be taken to break down phenylalanine. Much of the tyrosine in our body is unused and must be metabolized by a series of enzymes. Defects in tyrosine metabolism are called tyrosinemias. A defect in these pathways can also cause alkaptonuria. What is the enzyme that is defective in alkaptonuria? Homogentisate dehydrogenase. This results in a buildup of homogentisate. What are the clinical features of alkaptonuria? Many children are asymptomatic and not diagnosed until adulthood. Patients may have a blue or black discoloration of the skin and cartilage. When their urine and sweat are exposed to air, they turn black because the homogentisate is oxidized. Later in life, patients may have arthralgias from cartilage destruction and cardiac issues such as valve damage or arrhythmias. How do we diagnose and treat alkaptonuria? The patients will have elevated homogentisate in the blood and urine, and tyrosine levels will be normal. The treatment goal is to reduce homogentisate by having low levels of the precursors phenylalanine and tyrosine in the diet. There is a medication called nitisinone that can lower homogentisate, and vitamin C is sometimes used to reduce oxidation. Let's discuss maple syrup urine disease. What is the enzyme defect in this disorder and its normal function? There is a defect in branched chain alpha ketoacid dehydrogenase, which metabolizes the branched chain amino acids leucine, isoleucine, and valine. The buildup of these BCAAs, in particular leucine, and their alpha ketoacids in the blood and urine account for the clinical features. Thymine is a cofactor for the enzyme. The severity of maple syrup urine disease depends on residual enzyme activity, and there are different types of the disease based on this. What are clinical features of the disease? Initial symptoms include lethargy, poor feeding, and vomiting. The patient then develops neurologic deficits such as abnormal movements, spasticity, seizures, coma, and death within weeks or months if untreated. A specific finding is the smell of maple syrup or burnt sugar in the urine or earwax. The infant may also have signs of hypoglycemia. The buildup of BCAAs can inhibit gluconeogenesis, and leucine can stimulate insulin. This disease is part of the newborn screen, which detects high BCAA levels. What is the treatment for maple syrup urine disease? Treatment is with special formula and diet to restrict BCAAs. You can also supplement with thymine to enhance activity of the residual enzyme. Let's discuss cystinuria. What is the genetic defect in this disorder? The defect is in a transporter protein in the small intestine and proximal convoluted tubule that reabsorbs the basic amino acids cysteine, ornithine, lysine, and arginine. This results in high levels of cystine in the urine and the formation of cystine stones. What are the clinical features and diagnostic tests for cystinuria? Patients may start getting recurrent kidney cystine stones in childhood. Urinalysis will show the six-sided stones. There will be a positive urinary cyanide nitroprusside test. How do we treat cystinuria? In addition to adequate hydration, you alkalinize the urine with potassium citrate or other agents because the stones form in acidic urine. If this treatment fails, you can use chelating agents such as penicillamine. Let's discuss Hartnup disease. What is the genetic defects in this disorder? Similar to cystinuria, Hartnup disease involves a defect in an amino acid transporter in the small intestine and proximal convoluted tubule. However, the defect in Hartnup disease results in a failure to reabsorb neutral amino acids, such as tryptophan. What are the clinical features of Hartnup disease? Many of the clinical features result from the loss of tryptophan, which is necessary to synthesize niacin. Niacin deficiency causes the symptoms of pellagra, such as rash, GI effects, and psychiatric disturbances, as well as cerebellar ataxia. What is the treatment of Hartnup disease? The patient will consume a high-protein diet to replace the amino acids that are lost in the urine and intestine, and will supplement with niacin. Let's discuss the organic acidemias, in particular, propionic acidemia and methylmalonic acidemia. These are disorders of liver enzymes. There is impaired metabolism of amino acids, particularly valine, methionine, isoleucine, and threonine, and odd-chain fatty acids. Propionyl-CoA is a byproduct of the metabolism of these molecules. What is the enzyme defect in propionic acidemia? In propionic acidemia, there is a deficiency in propionyl-CoA carboxylase. This enzyme uses biotin as a cofactor and converts propionyl-CoA to methylmalonyl-CoA. This defect results in the accumulation of propionic acid in the blood and urine. What is the enzyme defect in methylmalonic acidemia? In methylmalonic acidemia, there is a deficiency in methylmalonyl-CoA mutase. This enzyme uses B12 as a cofactor and converts methylmalonyl-CoA to succinyl-CoA. This defect results in the accumulation of methylmalonic acid in the blood and urine. In both disorders, you can't synthesize succinyl-CoA. What is this molecule used for? Succinyl-CoA is a substrate in both the TCA cycle and in heme synthesis. What are the clinical features of these organic acidemias? The buildup of these organic acids inhibits gluconeogenesis. The neonate will have fasting hypoglycemia and elevated ketones. The buildup of ketones and other organic acids causes a high anion gap metabolic acidosis. The presence of ketones with hypoglycemia distinguishes it from other disorders of fatty acid metabolism. The buildup of organic acids also inhibits the urea cycle. The patient can have symptoms of hyperammonemia, including neurologic symptoms, vomiting, and poor feeding. Hypotonia may also be present. The buildup of methylmalonic acid and the deficiency in succinyl-CoA also indirectly reduces myelin synthesis. How do we treat these organic acidemias? The patient must follow a low-protein diet to reduce the production of propionyl-CoA. Their protein sources must have low valine, methionine, isoleucine, and threonine. The diet should also have low amounts of odd-chain fatty acids. Supplementing with carnitine may help, as well as using metronidazole, which can kill the gut bacteria producing propionyl-CoA. For propionic acidemia, supplementing with the cofactor biotin may help. For methylmalonic acidemia, supplementing with the cofactor B12 may help. Some patients may ultimately need a liver transplant in order to produce the normal enzymes. Let's discuss disorders of carbohydrate metabolism. These include the inability to metabolize fructose, galactose, and glycogen. There are two disorders of fructose metabolism. What are the enzyme defects in these disorders? In essential fructosuria, there is a mutation in fructokinase, which normally converts fructose into fructose 1-phosphate. In hereditary fructose intolerance, which is more common, there is a mutation in aldolase B, which normally metabolizes fructose 1-phosphate. What are the clinical features of essential fructosuria? The condition is usually asymptomatic, and no dietary restrictions or specific treatments are necessary. What are the clinical features of hereditary fructose intolerance? The clinical features result from the accumulation of fructose 1-phosphate. This depletes phosphate inside cells and results in the inhibition of gluconeogenesis and glycogenolysis, causing hypoglycemia. It damages hepatocytes and causes hepatomegaly and jaundice, and potentially cirrhosis. The symptoms start when the baby is weaned off breast milk and consumes food that contains fructose or sucrose. There is vomiting, failure to thrive, and severe hypoglycemia, which can lead to seizures. How are both disorders of fructose metabolism diagnosed? You can detect reducing sugars, fructose, in the urine. Hereditary fructose intolerance will also have abnormal liver function tests. The diagnosis can be confirmed with DNA testing to detect mutations in these enzymes. Treatment is only necessary for hereditary fructose intolerance. How do we manage it? The patient must adhere to a fructose-free, sucrose-free, and sorbitol-free diet. There are two main disorders of galactose metabolism. What are the enzyme defects in these disorders? In galactokinase deficiency, the enzyme defect causes failure to convert galactose to galactose 1-phosphate. In classic galactosemia, the more common and severe type, there is a deficiency in galactose 1-phosphate uridyl transferase, causing failure to metabolize galactose 1-phosphate. What are the clinical features of these galactose disorders? Both disorders will have an accumulation of galactitol in tissues, which causes cataracts. In galactokinase deficiency, the infant may also have difficulty tracking objects with their eyes, lack of social smile, and idiopathic intracranial hypertension. The clinical features of classic galactosemia are more severe from the accumulation of galactose 1-phosphate. This depletes phosphate inside cells and results in the inhibition of gluconeogenesis and glycogenolysis, causing hypoglycemia. It damages hepatocytes and causes hepatomegaly and jaundice, and potentially cirrhosis. The infant will have poor feeding, cognitive impairment, and failure to thrive. The infant is also at risk for E. coli sepsis. It's important to note that galactosemia will present in the first month because of breastfeeding. Fructose disorders will occur later when the baby is weaned off breast milk. Another important point is that galactosemia is a contraindication to breastfeeding. What are the diagnostic tests and treatment of galactosemia? The newborn screen will show elevated levels of galactose in galactokinase deficiency and elevated galactose 1-phosphate in classic galactosemia. Treatment is to avoid foods containing lactose or galactose. Let's discuss glycogen storage disorders. We will focus on glycogen storage disorders type 1 through 6, which also have eponyms. Glycogen storage disorders cause pathology in the sites where glycogen is primarily stored, including the liver, skeletal muscle, and heart. In most of these disorders, there is a problem breaking down glycogen. Less commonly, there's a problem synthesizing proper glycogen. Type 1 glycogen storage disorder is known as von Gurk disease. What is the enzyme defect in this disorder and its normal function? Glucose 6-phosphatase is defective. This enzyme is found in the liver and kidneys and catalyzes the final step of gluconeogenesis and glycogenolysis. It converts glucose 6-phosphate into glucose, required by tissues during fasting. What are the clinical features of von Gurk disease? The patient will have severe fasting hypoglycemia, causing lethargy, hypotonia, and possibly seizures. The patient will have elevated triglycerides and cholesterol. The patient will have elevated lactic acid and uric acid levels. The elevated uric acid can lead to gout or kidney stones. The patient will have hepatomegaly and nephromegaly from glycogen accumulation. How do you treat von Gurk disease? Patients should eat frequent small meals to avoid fasting. Patients can also eat uncooked cornstarch at night, which is a slow-releasing carb, to prevent overnight fasting. The patient should avoid fructose and galactose because these cannot be metabolized. Allopurinol can be used to prevent gout and kidney stones. Enzyme replacement therapy has not proven effective for von Gurk disease. A liver transplant may be necessary if the previous interventions are not successful. Type 2 glycogen storage disorder is known as Pompe disease. What is the enzyme defect in this disorder and its normal function? In Pompe disease, there is a defect in lysosomal acid maltase, or alpha-1,4-glucosidase. This enzyme breaks down glycogen into glucose in the lysosome. What are the clinical features of Pompe disease? Infants will present with difficult feeding and failure to thrive. They will have hypotonia and muscle weakness. They will have respiratory muscle weakness and difficulty breathing. They may also have hypertrophic cardiomyopathy and arrhythmias. The most common cause of death will be respiratory failure. How do we treat Pompe disease? Pompe is treated with enzyme replacement therapy. IV infusions of the acid alpha-glucosidase are given. Type 3 glycogen storage disorder is known as Cori disease. What is the enzyme defect in this disorder and its normal function? In Cori disease, there is a defect in glycogen debranching enzyme, which has alpha-1,6-glucosidase activity. This enzyme removes the last 4 glucose molecules from a branch of glycogen. What are the clinical features of Cori disease? The symptoms occur in early childhood. The most common symptom is hepatomegaly. The patient may also have muscle weakness, delayed growth, and fasting hypoglycemia. Blood lactate levels are usually normal. Less commonly, patients may have heart problems. How do you treat Cori disease? The patient should eat frequent small meals to avoid fasting. Patients can also eat uncooked cornstarch. The patient can eat fructose and galactose, unlike von Gurk. Enzyme replacement therapy is not available for Cori disease. Type 4 glycogen storage disorder is known as Anderson disease. What is the enzyme defect in this disorder and its normal function? In Anderson disease, there is a defect in glycogen branching enzyme, which creates alpha 1,6 glycosidic bonds. It's different than the other disorders we're discussing here because it's a defect in making proper glycogen. What are the clinical features of Anderson disease? The infant will have failure to thrive and hepatosplenomegaly. In certain variants, the infant may develop cirrhosis. The infant may have hypotonia and cardiomyopathy. Later in childhood, the patient may develop hypoglycemia and neurologic symptoms such as peripheral neuropathy. How do you treat Anderson disease? The patient should eat a high protein, low carbohydrate diet to reduce glycogen storage in the liver, but also to have substrates for gluconeogenesis. The patient should be given frequent small meals to avoid fasting, and patients can eat uncooked cornstarch. In some types that lead to cirrhosis, a liver transplant may be necessary. Type 5 glycogen storage disorder is known as McArdle disease. What is the enzyme defect in this disorder and its normal function? In McArdle disease, there is a defect in skeletal muscle glycogen phosphorylase, also known as myophosphorylase. This enzyme normally breaks down glycogen. What are the clinical features of McArdle disease? The patient will have muscle weakness, stiffness, and pain. The patient will also have exercise intolerance and may experience a second wind phenomenon, where after an initial period of fatigue, they have improvement in their exercise tolerance. In severe cases, there can be muscle breakdown causing myoglobinuria or rhabdomyolysis. What is a diagnostic feature of McArdle after a patient exercises? After exercise, there will be a flat venous lactate curve instead of significant elevation. There will also be exaggerated ammonia levels. What is the treatment of McArdle disease? The patient should have a diet rich in carbohydrates, particularly before exercise, and should avoid intense exercise to prevent muscle damage. Type 6 glycogen storage disorder is known as HERS disease. What is the enzyme defect in this disorder and its normal function? In HERS disease, there is a defect in liver glycogen phosphorylase. This enzyme normally breaks down glycogen. What are the clinical features of HERS disease? The disease appears in infancy and early childhood. and the first sign is often hepatomegaly. The patient will have hypoglycemia, more pronounced during fasting, failure to thrive, and growth delay. The patient may have elevated ketones, lactic acid, and hyperlipidemia. In severe cases, there may be hepatic fibrosis. What is the treatment of HERS disease? The symptoms of this disease often improve as the patient gets older, and some patients may not require treatment. The treatment is similar to other glycogen storage diseases involving liver enzymes. The patient should eat frequent small meals to avoid fasting and uncooked cornstarch. Let's discuss disorders of nucleotide synthesis. These include purine salvage disorders, purine catabolism disorders, and erotic aciduria. Purine nucleotides can be synthesized de novo or recycled by the salvage pathway after purine catabolism. The end product of purine catabolism is uric acid. Name a purine salvage disorder, the enzyme defect, and the enzyme's normal function. Lesch-Nyhan syndrome is an X-linked recessive disorder that results from a defect in the HGPRT enzyme, causing a failure to produce IMP and GMP, leading to increased de novo purine synthesis and uric acid production. What are the clinical features of Lesch-Nyhan syndrome? Symptoms usually start after 3 months. Patients present with self-harming behaviors such as finger biting, lip biting, and head banging. They will have developmental delays and cognitive impairment. Patients may have involuntary muscle movements such as chorea or dystonia, or muscle spasticity or hypotonia. They may have orange-colored urate crystals in the diaper and symptoms of gouty arthritis and kidney stones, similar to von Gurk. What is the treatment of Lesch-Nyhan? High uric acid levels are prevented with allopurinol and a low purine diet. There are no specific treatments to prevent neurologic dysfunction. Medication can be given to prevent muscle spasms. Measures are taken to avoid self-injury from biting. There are many disorders of purine catabolism. One of these is adenosine deaminase deficiency. What is the normal function of the enzyme, and why does its deficiency lead to pathology? Adenosine deaminase converts adenosine and deoxyadenosine to inosine and deoxyinosine, which are further broken down and excreted. When the enzyme is deficient, adenosine accumulates and inhibits ribonucleotide reductase, reducing the production of deoxyribonucleotides and DNA replication. This results in a deficiency of B and T lymphocytes and a form of SCID, severe combined immunodeficiency. What are the clinical features of adenosine deaminase deficiency? Patients are susceptible to increased infections from bacteria, viruses, and fungi. They will have recurrent pneumonia chronic diarrhea and skin rashes. Patients will have failure to thrive. What is the treatment for adenosine deaminase deficiency? Treatment is with bone marrow or stem cell transplantation and enzyme replacement therapy. Gene therapy is also being used, and it involves introducing a functional adenosine deaminase gene into a patient's own stem cells with a viral vector, which are then infused back into the patient. There are many disorders of pyrimidine synthesis. One of these is hereditary orotic aciduria. What enzyme is deficient in this disorder, and what is the enzyme's normal function? In hereditary orotic aciduria, there is a deficiency of the enzyme uridine monophosphate synthase, which converts orotic acid to UMP. This impairs the de novo synthesis of pyrimidine and results in an accumulation of orotic acid. What are the clinical features of hereditary orotic aciduria? The patient may have failure to thrive, developmental delays, and intellectual disability. They will also have megaloblastic anemia not correctable by folate and B12. Patients will have orotic acid crystals in the urine, which can lead to obstruction and kidney damage. The patient may also have white cell deficiencies and recurrent infections. What is the treatment for hereditary orotic aciduria? Patients can be given uridine monophosphate or uridine triacetate, which can be converted to UMP. Another inborn error of metabolism that can have elevated orotic acid is ornithine transcarbamylase deficiency, a urea cycle defect. However, OTC deficiency will have elevated ammonia levels and will not have megaloblastic anemia. Thank you for joining us for the first of our 2 lectures on inborn errors of metabolism. We hope you learned a lot. Additional notes on this topic, as well as mnemonics, will be available at lectureboss.com or by following the link in the video. Take care.